is the third molar. You can see the foramen ovale. You have to find the maxillary sinus. Just lateral to it, you will find it. And this is almost mid-pupillary line where you are going.
Right.
Now, the position of the patient is very important. There is mild extension, but the important thing here is when you are doing a lateral X-ray, sort of you have to see that it's all parallel. So first, what I do is I break the parallel nature. Abhi shoot कीजिए. Okay, now look here.
Yeah.
If you look at the triangles, those
Camera be focused center your image. Yeah.
आप थोड़ा सा इधर नीचे की तरफ लाएं, हल्का सा.
Now you can see.
Yeah. So if you look here, you are not able to see the triangles very well.
Right.
Now have a look. अभी एक shot लीजिए. अब shot लीजिए. So all this is not good for you. अब shot लीजिए. All these images don't नहीं ऐसा. हाँ अब कर. You appreciate now?
Yes. Yes.
So now we are like back on and we are ready for stimulation. What I am using currently is stimulation कर लीजिएगा 50 hertz per millisecond with a we start with a voltage of 0.3.
Camera can be focused on the generator. So actually the patient is sedated.
Yeah.
You are giving.
Some amount of fentanyl, and because I was able to get it on first pass, so we did not sort of require it.
Right.
Take short patient. Yes, this is all just about. So it gives you a basic idea. That's about.
Can you focus on the machine, radio frequency machine?
Shoot, please. Okay. This location to begin with.
Okay.
चलो अभी स्टिमुलेशन करना प्लीज ऑन कर और बढ़ाते जाए अब तो तेज तो नहीं होगी बढ़ाएंगे 0.3 तक ले जाएंगे हाँ ओके नाउ स्टिमुलेशन ऑन नहीं 0.3 ऑन नहीं you have to switch something to on. Okay. अभी आपको कुछ लग रहा है? वैसे ही लग रहा है? Okay. So he confirms that he is feeling the same amount of pain.
Right.
So और उसी जगह पर आ रहा है. हाँ. So now little bit of it. And आप 75 degree पे ले जाएंगे. Now we'll give RF of 75. No, this is high. Okay, and for 60 seconds you can switch it on. Yeah, you're given.
So, which have we have targeted here?
You are targeting E3, right?
Right now we know. So as I told you, I tend to go to the higher dermatome first.
Right.
And then, so he's having pain. And I'm giving the current, he's moving and he's having pain. Which sort of confirms.
So you don't give any kind of sedation or
sort of you know quickly finding the foramen and the patient is having a lot of
Sir, you are not going to do any motor stimulation?
I do for P3 now because once he's sedated for P3 I will show you that. Say for 60 seconds.
Sir, just a question, not actually a question. If you resume the V2 first and then come back to the V3, as the Dureja was saying that probably the vision effect will be there and you will actually appreciate. Is that?
Yeah, so for that you just need to increase the stimulation voltage. So instead of 0.3, because right now we got at 0.3. So if it is not coming again, we give it at 0.5 or 0.7. And also I look for the motor stimulation at this point of time.
Okay.
X-ray please. X-ray please.
Why this X-ray again, sir? Okay.
X-ray please. Looks pretty good to me.
Okay.
Are you able to appreciate all
Yeah.
So I fired the stimulation at 0.5.
So you always do perform single lesion.
75. So the so he is already started having pain again. Can you appreciate?
Yes, sir.
Yeah. So stop it. Continuous with जाएंगे. So we have got good stimulation at 0.5.
Right.
Yeah. So as you see, we can easily get it, and there is a lot of wincing to 75-degree again. 75, yeah, start. You have to give. अभी आप अच्छे से दे सकते हो.
So do we are not doing the motor stimulation here?
Yeah. So he was wincing and a lot of motor activity. Now, you know, there's a difference between this machine and the machine that the one that I have, it's not continuous stimulation. Sorry. 𝐂𝐚𝐬𝐿𝐵𝐷, bus. So in that, there is a point stimulation. So when I push the pedal, stimulation. So, you know, I'm able to see the jaw.
Okay.
Like I've also shown in my clip that the lady's jaw was opening when I was giving a test stimulation.
Right.
Yeah, everything was same. So we do something in reverse. Get the patient ready, and we just have one machine. Now, Ravi and Datta, they'll sort of, as they're pulling out the needle, we'll demonstrate. Instead of putting it.
Demonstrate what?
Like how we meant, how,
Okay.
you know, the position of the wheel. So, come to this side. You also come. So, I'll remove the electrode as of now. So, this is the electrode. I am not sure what size sir used, but we have here a 15 centimeter needle and the probe. So, we have used that one. Now, still it, please, sister.
This you have got, this is your own?
No, this you have. But the problem was compatibility नहीं होगी
Is it possible the patient will bite it because of pain?
No, generally doesn't. And you are outside the, you go to the hospital, feel out the needle. Yeah, SPO to come out. Okay.
Because you are putting in the needle and he has severe pain, he might just bite your finger off.
You can put a mouth gag and then do it. That is more safer.
No, you don't really require it.
Okay.
Okay. एक X-ray shot लीजिए please. हाँ. Okay. Now धीरे से pull back करना about say half a centimeter, and then we'll show them. हाँ. Shoot करिए. Okay. So this is where the foramen ovale is typically there. Okay. जहाँ पर needle का tip है.
Right.
Okay. Now we are pulling it further. If you look down below, it is just crossing the posterior part of the mandible. The hard part. Now pull it again. Now what Datta is doing is he is feeling the needle just lateral to the buccal mucosa. You are feeling the needle, right? थोड़ा और pull करो बाहर. Yeah, pull it So I'm asking him to feel the third molar. If you appreciate on the X-ray, see we have just gone lateral to the third molar. Lateral में आप लोग को दिख रहा है?
Yes.
Yeah. So there is also an element of psychological dependence of all these drugs. Like we saw what Deepak was presenting for pregabalin. Similarly, there is a little bit of oxcarbazepine or carbamazepine group as well. So it is better to gradually taper it off. And as far as your question is, I would say around 50 to 60% of my patients, I really don't have a hard data, but I'm assuming that about 50 to 60% of my patients are totally off drugs, and the rest may be on minimal amount, mostly SOS basis.
Ashish, do you use baclofen in any of your patients?
Ashish, the question is, do you use baclofen in any of your patients?
Yes. Is very potent, but then as you are well aware that lamotrigine has a lot of dermatological and other side effects, and it has to be really gradually increased vis-a-vis the other group of drugs which you can sort of increase a little faster. So lamotrigine for me comes a little later. But I must tell you, if the patient is not responding on carbamazepine and
Yes.
Sir, we'll go with skill number 1.
Okay, Ashish, we'll have to interrupt you.
Sir, what do you have, sir?
Just for 2 minutes, I wanted you to show a patient with cesarean RF.
Yes.
And he is there for last now. बताओ भैया कैसे हो? कैसे आप दर्द है? हाथ लगा के देख। पहले क्या होता था? पहले ये ले, अब कुछ नहीं है, खुश है? ठीक है, सुन है, थोड़ा सा सुन है, थोड़ा सा सुन है, सुन है। So, when we are asking about carbamazepine, see, if you have such a big container, I have to stop carbamazepine. So, immediately reduce it down to 100 milligrams and after 15 days, we never call anyone anymore. After 15 days, they stop all the medicine. And till the time on that, they don't order it. They should not order it. ठीक है भाई?
We can have second case in your OT, sir.
Yeah.
Or Rajiv told me that you felt it was unsuitable for.
Yeah, I will not. I will not.
Right.
Right. Thank you. Sure.
Sir, when we can expect a peak effect of this?
Dr. Dureja, one question is there.
Peak effect after RFA.
When can we expect the peak effect to come, sir, for this?
See, normally, the return is immediately, like what you see.
Right.
But yeah, sometimes the patchy cut may be initially, but the thing and intensity of pain will not come back after the there might be some cause of as the patient themselves say without cause with compound use again, and slowly and steadily within 2 weeks. There should be an immediate relief, maximum.
Right.
So we immediately shift the patient, after a couple of hours we send the patient back home.
Right.
Sir, our patient has been called to OT, sir. Our patient is being shifted there. Okay, sir. My next patient is Somati, sir, a 45-year-old female. She came with complaints of low backache relating to left lower limb since last 1 year, sir. Increase in last 4 months. She has now new onset neck pain relating to left upper limb since last 1 week. There is no history of trauma, ball and bladder involvement, and any claudication, sir. On clinical examination, her bulk tone are normal, sir. Power is 5/5 in all the 4 limbs across all joints. Reflexes are 2+, sir. Sensory examination is normal. On MR imaging, patient has cervical straightening with small central C5-C6 PIVD and central disc at L4-5 level and the right paracentral disc at L5-S1 level. Sir, our patient is currently planned for cervical root block now and will be planned for decompressive surgery, lumbar decompressive surgery for L4-5, L5-S1 PIVD, sir.
Can you show the imaging properly?
Haan, sir.
Cervical and then you show the lumbar also.
Sir, this is the imaging. Axial.
With lumbar.
इसको zoom out.
Lumbar angle.
Abhishek, where is the cervical axial?
Sir,
Axial cut.
sir, axial cut was not available, sir.
Sorry?
Sir, axial cuts were not there, sir.
Patient. So please arrange.
Yes, sir.
Patient is having the cervical MRI.
Yes, sir.
Show the get the films from patient and show it by putting on the V box.
Okay, sir.
Shows the lumbar also.
She has got lumbar MRI, sir.
Shows the lumbar.
Lumbar films you show lumbar axial.
Yes, sir, I'm showing, sir. Sir, this is a lumbar MRI, sir. She has disc at L4-5 and L5-S1 level. So zoom out करना.
Where is the disc?
Zoom out.
And what about the complaint of related to the lower limb?
Sir, she had low backache relating to left lower limb since last 1 year, sir, and it has aggravated since last 4 months, sir. But there is no history of claudication and bowel and bladder involvement, sir.
This patient we have planned for lumbar discectomy, but pain.
So, just that's why I wanted to know what is your at what time you decide the patient should go for discectomy? How will you decide? Because normally, if you say the patient doesn't have any or significant motor involvement.
This one we had kept for both cervical plus lumbar, but sir feels block won't help her. This should be operated. This is planned for surgery, but we wanted her to give both pain relief for cervical plus lumbar. But Dr. Dureja says ki lumbar no need for pain block, directly go ahead with surgery.
Okay. That's
in
why
those cases we can go ahead with blocks. That's why she got kept. Yeah. That's why she was kept
Because
for.
sometimes the patient waiting for the surgery also because the pain
Yes,
is
yes,
sometimes
yes.
severe, so
Many
that it
times
can be really
many times these pain procedures help you in buying time.
buying time,
Buying
exactly.
time. Like patient is not ready for surgery because of some function or some official commitment. So
Exactly.
in those
At least
cases,
in our setup we have
it's
seen
a
that.
OPD basis thing. You can just go and have it in 2 hours, and patient can continue with his routine life. So in many times it helps in buying time.
Obviously.
Yes, sir. Side. And many times, sir, when there is a disc is not that prominent, where it's not a clear-cut surgical case, in those cases it helps in breaking the vicious circle also. And those cases get many times after breaking the vicious circle, pain relief is there. You rehabilitate them by physiotherapy and all, and many times you are able to cure him without any further treatment. Abhishek, patient taken on table.
The patient is coming, sir. She has not reached OT yet. Sir.
What about OT-2?
OT-2 खत्म. ये लो इसको निकाल लो. OT-2 का करेगा.
नहीं पेन है मेरे पास. Abhishek, who is there in OT-2? There is a question from the delegates. What is the role of hyaluronidase? Is there any role of using hyaluronidase along with steroids when we are giving the root blocks? Dr. Navdeep, can you comment on this?
So mostly when we expect lot of fibrosis or the previous surgeries, then we more use the hyaluronidase to break the fibrosis and for the better spread of the steroids for that purpose.
Okay.
That epidermolysis.
Failed back syndrome case. Yeah. Okay. Another question is what should be the acceptable impedance in RF medial branch block? Like it was around 400 to 500 in trigeminal. So is there any such guideline for RF medial branch block? Up to 700.
Because there we are near the bone, so the higher impedance is acceptable.
Another question is, should we dilute the contrast while doing the radiculogram? I think it's no, we should not dilute because we need a hyperbaric solution there.
Actually, during adhesiolisis, sometimes you may need because later on because you are using so much of dye and all. But in normal transforaminal or epidural, because you are using hardly 1, 2 or 3 ml.
0.2 or point.
No, in lumbar epidural or transforaminal.
Okay.
In transforaminal, obviously you are using a smaller volume.
Yeah.
Just see how much contrast you are needed for reaching that nerve root or DRG involvement and the epidural.
It's usually, I think, less than a ml.
Less than ml if it is done.
So then no need to dilute it.
So in that case, obviously it is be seen better.
But sometimes we have used with the double dilution of the dye,
Okay.
and the only advantage with that that it easily clears. So if you need to reposition the needle, then you can see the needle tip. So sometimes you may double dilute the contrast agent.
So what are those cases where you want it to get cleared early as possible?
So suppose if we the dye spray is not proper, and if we want to repositioning of the needle, then the needle tip will not be visible if the contrast is not diluted.
But you have already given it.
No, the contrast we have given, and the dye spread is not optimal.
Okay.
Then you have to reposition the needle to get the spread in proper way.
Okay.
So for that, sometimes the diluted contrast may come help. But otherwise, you can when and as you perfect the procedure, you may not need to dilute the dye.
Most of the interventional
Hello?
in spine,
OT-1 back with you, sir.
so we hardly use
Just a minute.
maximum
OT-1,
4 ml.
you are connected.
Dilution is important if you are anticipating a large volume of dye to be used, like in visualization.
Okay.
ठीक है, field back surgery. So it's but in
Camera on the MRI, please. Camera on the MRI.
Thank you. Yes, Abhishek. Yeah, we are there with you, Abhishek.
Yeah.
Dureja, we are there with you.
Okay, fine. So we just have a look at the MRI imaging. Anybody can show the MRI? Yeah. So this
Cervical.
yes, cervical. So she has a left-sided radicular pain, and you can see the disc bulge, which is causing pressure on the left-sided root. सीधा करो, सीधा करिए, सीधा करिए सर, सर सीधा करिए, दिखाइए, शूट मारिए, दिखाइए.
Yeah,
So
symptoms on the left,
she has severe symptoms on the left side.
left side is more.
Yeah, दिखाइए सर. Yeah. So we like yesterday we saw a cervical epidural where the nerve compression was more on the right side. This time it's the left side. Dr. Rajiv, your conference has become international. we have a delegate from UK.
Yes, sir.
He's
Yes,
a
sir.
dear friend and he's an alumni of All India Institute of Medical Sciences way back in 1980s.
Thank you, sir. Thank you.
Sir,
It's all because of you, sir. We owe it to you, sir.
So I welcome Dr. Praveen Kalia.
Yes, sir.
Sir, please enlighten the level which you selected and how.
So we are going at C6 and C7. This is what? No, C7 and T1 level. Right? You can see on the C arm, we have given local anesthetic as per the interlaminar space on C7 and T1.
Ravinder, please check the sound quality. We are not able to hear clearly. It's blurring.
So the two things which we require is a epidural needle, 2 His epidural needle, 18 gauge, and a special loss of resistance syringe, right? So we have already given local anesthetic. Any sedation given, please?
So this local anesthesia is given in the skin, subcutaneous tissue, and in
And
the
the
interspinous area.
Yes, interspinous area.
Okay, sir.
Please shoot. Shoot. Yeah. So you can see now I am going midline, but I will redirect it little laterally on the left side. Shoot, please. Yeah. Now you can see. Again, shoot, please. So you can see the position of the needle. I am on the left left epidural space.
Yes, sir. This is slightly. This is exactly in the midline, no, sir?
It is going from the midline, but to the left paravertebral.
Yes, sir. From
Left
entries from midline, and you are going on the left side.
Yes, yes.
Okay, sir.
This is not a paramedian, so I am just gentle push to the plunger. Now I have reached the ligamentum flavum.
But even if you are in midline, still it can go. The drug can still go.
Yes, it can.
Yes, sir.
हिलेगा नहीं.
So you are not going to check with the lateral X-ray, sir?
We will, but the only thing is that big breasts and shoulders. So I have already reached there. You can see the loss of resistance. I have reached there. Okay. So from sudden these things which I was showing now, I can push my air easily. Okay.
Yes, sir.
So final position, please. Final position. Yeah, this is the final position. Now comes the die.
So many times on lateral view we are not able to see it. Then
Yeah,
what
I
is the
will
solution in that case?
Yeah,
How you confirm your?
Can we take the lateral view, please? So the die is preferably on the left side. I will push some saline to see the nerves, but before that I am. दिखा.
दिखाओ थोड़ा सा अपनी तरफ लो ना श्याम अपनी तरफ हाँ और अपनी तरफ लो yes yeah you can see now the drug in the left this is the epidural space you can see that you can appreciate the epidural space
Yes, sir.
and the roots also
Yes,
so
sir.
I'll push some more dye to show you
Okay, sir. And how much deep to posterior spinal line we can go, sir?
deep means like you got to pierce the ligamentum flavum and enter into the epidural space दिखाना ठीक है right so you can see the drug in the epidural space
Yes, sir.
bathing the nerve so I will now give some saline to delineate the roots you have to be very gentle when the needle is there
This is saline, sir.
this is saline we don't put any local anesthetic in this
Okay, sir.
check please so you can now see both the roots both the sides I'm just turning the bevel on the left side and pushing in more dye check please yes so just to complete I will push a catheter which will preferentially go on the left side this is the catheter into the cervical epidural space yes so you may irritate some nerve while pushing this catheter and patient may have some sensation in the upper extremity okay so we put the dye show please now you see now I'm going more yes it is going into the left upper roots also
Yes, sir.
pushing
Till what level it's going up, sir?
it's going up to C5 now show please sir. No it's going a little higher up
And
also.
where is the tip of your catheter, sir?
I'll just show you can I have some more dye
Does this catheter has tendency to penetrate dura and go inside
no
on pushing?
this is a very mild catheter no it cannot
Okay.
the one which we showed the Rax catheter which has a steel stellate can but
Okay.
not this one this is a very pure very
Very soft
flexible
catheter.
plastic now you show please
Okay, sir.
show please show catheter दिखा सकते हो नहीं कोई रेजिस्टेंस नहीं कोई रेजिस्टेंस दिखा या यू कैन सी यहाँ पे ऊपर दिखाना और ऊपर जा हाँ या ये these are the roots which you basically see मैं वो तभी दाई डाल के दिखा रहा हूँ आप दिखाना शेखर yeah so this going up to C4 now so our target is C5 C6 so we are bathing the nerves beautifully on C5 C6
Yes, sir.
so then comes the time to give the drug which is 8 milligram for 80 milligram of
How much drug and what drug you have given, sir?
I am giving triamcinolone and it is 80 milligram
Okay. Are you mixing local anesthetic also in
no not in the cervical level
there? Okay, sir.
as I told you yesterday that it
Yes,
can
sir.
block the motor nerves so going easily
Is there any role of controlling the speed? Means it should be given slowly or
this is a fantastic question actually I've been doing a study on the speed of giving the drug because if you push it you know it will go into the epidural space
Yes, sir.
so if you give it slowly it is going to bathe the nerve which is our final target
Yes.
so that's why you can see I am not being very aggressive I'm going very slowly there's no resistance but I'm going very slowly so deliberately so that it covers the entire nerve and that's why we don't push a lot of saline also after this just clear off the catheter and that's good enough.
And one more thing,
Sure.
sir. This catheter you have inserted inside, it's having only one hole at the tip, or there are multiple
No, there are
holes also?
multiple holes. There is no hole at the tip.
Means
Rather-
along the whole length, which is there inside
Yes.
the interspinal canal, the whole area will get the drug.
Yes, I will show you the catheter when I take it out. But
Okay,
I
sir.
wanted to show you the C arm now.
Yes, sir.
Can someone point the nerve root at C? आगे इधर नहीं left side. हाँ ये यहाँ से now ये the whole thing, yeah, these are the roots. नीचे आ जाओ, नीचे आ जाओ. ये this is the root. Yeah. So that's why we abandoned cervical root sleeve block. We rely only on the epidural, safe and effective. So some of the drug.
Sir, in all of your cervical epidural, you use triamcinolone or in any case dexamethasone?
No, I don't use dexamethasone. I use either this or I use depomedrol. I use depomedrol.
Sir, depomedrol is also there. If you want to use, it's there available in OT.
Okay. So I use depomedrol, but I thought there would be a lot of eyebrows raised at depomedrol, so I am using triamcinolone.
It's okay, sir. Whatever is your practice, please continue with that.
Okay, okay. But I think I'm finishing now. Yeah, so putting some saline.
This is saline now, sir.
This is just saline to push the drug. Okay. Again, check on the C-arm. Please check on the C-arm. Yeah. Now you can see right from C2, C3. I'll just show you. This is C2, C3, C4, C5, and C6.
Okay.
Through a needle placed on the left epidural space. Patient has left-sided symptoms. I don't want to waste my drug on the right side.
Okay.
And I'm achieving the spread of the drug in all the roots in the left side.
So total around 4 ml, of saline we have injected.
And,
any times you have felt any epidural cord compression in such cases? Any
Not
time in
really.
your life?
No, not at all.
Okay.
So I'm just showing you this catheter. आप दिखाएंगे जरा इसको. So this is like from the side. It is never from the tip.
Yes, sir. We are able to see,
you
sir.
are
Yes,
able to
we are able to see, sir.
So there
Multiple
are
side holes.
three, four holes from
Yes,
where
sir.
the drug is coming.
Tip is, I think, closed.
Tip is closed.
Yes, sir.
So the tip is very blunt and closed for the
soft.
same, for the reason which you asked me.
Yes.
It doesn't puncture, but you have to be careful. So
Thank you, sir.
thank you so much.
Thank you so much, sir.
And thanks a lot, Rajiv.
Thank you so
I
much.
have finished my quota. I'm going back. I really enjoyed it. I'll come and meet you for 2 minutes. Thank you
sir.
so much, the
Thank you.
audience.
Thank you.
Lovely audience. Loved it. Thank you.
Thank you, sir. Thank you so much. Hello, OT2.
Hello, Dr. Ashish, sir. You are connected, sir.